Hello. Good evening, dear guests. Welcome to today's presentation by the Turkish Pediatric Radiology Society. I will be your introductor for the day. And it's April Fool's Day. You all got pranked. Anyways, here's your real introductor. Love, the person who pranked you.
Merhabalar. Good evening, everyone. So we wanted to make a little joke because today is April Fool's Day and we are the Turkish Pediatric Radiology Society. And we happen to have the volunteer performer for that. So thank you. And then today's lecture will be, today our guest will be Dr. Felice D'Arco from Great Ormond Hospital in London. And our moderator is Dr. Ali Yıkılmaz from McMaster University. And Dr. D'Arco will be presenting us his cases. And before that, Dr. Ali Yıkılmaz will make a short introduction. Thank you for joining us.
Hi, everyone. I'm very happy to introduce one of my best friends, Felice D'Arco, as a presenter today. He's an excellent neuroradiologist, and we've been friends since the fellowship at SickKids together. In 2015, he completed the fellowship. We were together. He is currently one of the teachers in ENSPR in one of the in ENSPR courses, and also he's an editorial member in the Neuroradiology Journal. He is very active. He has excellent lectures. I follow his YouTube channel. I listen to his lectures. He's really good. Welcome, Felice.
Thank you very much. Let's start sharing.
Yeah, please.
You will comment the first picture because you put the picture on.
Yes,
so
okay. So other than his professional career, Felice is a typical Italian. He is a really good cook. He has nice cooking skills and he can cook the best pasta in the world for you. That's how we met years ago. And you can see that also when we were fellows, we used to call him Darkovich at that time because he was very brilliant, and Barkovich was our we were really inspired by Dr. Barkovich. So we used to call him Darkovich. And after years, last year we made a meeting and he actually gave a lecture after Dr. Barkovich. So he's, I think I can call him the second Darkovich today as a joke.
We fulfilled our dreams.
Yeah, so the dreams came true, right? George Taylor, Darkovich, Markovich. It was good. So please go ahead and start your presentation, and I will be helping you for the polls, and I will be taking the questions and ask you the questions. So if anyone wants to ask a question in the audience, please type in the Q&A box so I can just directly ask to Dr. D'Arco, and we should do this case by case. We don't have to wait for the end of the lecture.
Yeah, okay. Thank you very much. It's really a great pleasure to be here with you. And this is really a lecture with a lot of cases of neck masses in children that can be quite tricky. I love head and neck in children, a bit neglected area. And this is structure of the talk. It's case-based presentation. There will be cases, teaching point, radiological differential. And as Ali said, you will have several pools. Just we have a lot of cases. We don't need to reach the end of the lecture if we don't have time, but please try to answer the pool as fast as you can so we get to see as many cases as possible. So let's start with this warm-up case. I like very much to show in my neuro-oncology and head and neck talks because it's really, really interesting. This is a 10-week-old girl born with this lesion in the periorbital region, was obvious, But the interesting thing of this case is that as radiologists, we can really connect the dot, and we can really understand how you see something in the neck, something somewhere else. And these things taken in isolation are not really diagnostic, but together we can sometimes reach a very complex diagnosis. So let's start with the head and neck lesion. You see here the coronal, the T2 stir that I showed you. And of course, when you do head and neck masses, please all the time get rid of the fat in T2 and in T1 post. In T1 pre, you need the fat as a passive contrast media around the lesion. So that's the basic of the technical approach to head and neck. So T2 with fat saturation, so steer or spear, and T1 normal T1 pre, but then T1 post with a fat saturation. And also, so we see the lesion. Also look at the diffusion, very nasty aggressive lesion. There is restriction of the diffusion plus nodal enlargement. This is not reactive even in a neonate. But then we keep looking and we have another lesion. And look, those of you who are neuroradiologists, adult neuroradiologists, this lesion does not enhance. It's very, very unusual for a mass in the adult brain to not enhance, but still, again, diffusion restriction, intermediate T2 signal. So this is the combination finding, intracranial neck congenital, because the child was born with that. So, and now you can read the pool, Ali.
Yes. So what is your diagnosis? A, metastatic neuroblastoma. B, RMSPAX7 fusion with brain and nodal metastases. And C, multiple tumors from, let me actually share this with you so you can vote in the meantime. So multiple tumors of SMARCB1 mutation. D is atypical tuberculosis in hypogammaglobulinemia.
Right, 10 seconds,
Well,
guys.
it was difficult to read this, Felice.
Yeah, anyway, RMS is rhabdomyosarcoma for those of you who are not familiar with the acronym, just for space. And SMARC B1, yeah, it's just a mutation, PAX7, another mutation. You can start voting.
Okay, so ending the poll now. Share results. So most people said B.
Yeah,
And
that's correct. That's correct. So that's very, very good. I mean, half of you didn't get it right, but this is, of course, a complex diagnosis. But what I wanted to show is a couple of teaching points. This in the brain was an ATRT, okay, a typical teratoid tumor. Is one of the three main embryonal tumor in the brain. And there is something in the head and neck, which is soft tissue, rhabdoid tumor, and both are due to SMARCB1 mutation. Why is so important? Because if we see an aggressive mass in the orbits, it's just an aggressive mass in the orbits, they need the biopsy. If we see something in the brain showing diffusion restriction, we think embryonal, but we cannot go further than that. This combination allows us to do histological and genetic diagnosis, just looking at the images. And this is just one of these few examples. But of course, this is very rare. But what I want to stress is that every embryonal tumor in children show striking diffusion restriction, even though some of them do not enhance, like some of the ATRT do not enhance, some of the so-called ETMR, which is embryonal tumor with multi-layer rosette, do not show enhancement, and also some subgroup of medulloblastoma, like the type 4, do not show enhancement. So completely different from the adult world. Of course, embryonal tumor are in young children. So in your differential diagnosis of the mass in children, use the age as a very important bullet in your gun, okay? This is another question that Ali put. Yeah, please, Ali.
Okay, so let me find the question. So which one is true about Italy? Italy has a free wine fountain. B, Italy has most UNESCO World Heritage Sites in the world. C, Italy is the 5th most visited country in the world after Turkey. D, Italians consume 14 billion espressos each year. E, all of the above. because the first question was really difficult. That's why I wanted to put an easy question, Felice.
And
And
of
we,
course, guys, oh, this is, 1st of April, but if you have any doubt about what we are discussing with Dali, just type it in and we'll try to explore any question or element of differential diagnosis and so on. Yeah.
sure. Okay,
I'm
so
the one consuming most espresso. I mean, good percentage of that. Oh, you see,
yeah,
90%.
all of the above, are they true?
Yeah. So this is, there is a free wine fountain that I never visit, and this is why I'm still able to do this presentation. Italy has a lot of UNESCO World Heritage sites, and for some reason, is only the fifth most visited country, but very close to Turkey. And yeah, I myself, I consume a lot of espressos. I never use this close to the espresso. This is close to wine normally, this cantuccino, this biscuit, but still. All right, so let's come back to the radiology. And this is a 1-year-old baby girl with this mass, okay? So the first thing you think as a radiologist is, okay, this is a young, is an infant, and how the mass look like, how the lesion, what we are looking looks like, what are the radiological characteristics. But first of all, you need to make sure your technique is right. So my suggestion is that every time you see a mass, you must give contrast, because contrast helps you a lot in the differential diagnosis. And in this case, we gave contrast, and look how homogeneous is the contrast. Enhancement. However, the mass is not completely homogeneous. There are these areas of T2 hypointensity. So remember, T2 hypointensity in the mass. So the characteristic of the mass, how we will describe in the report, but these are useful not only for description, but to reach the diagnosis, are well defined. Look at the ADC here, free diffusion. This is not aggressive as the other one I showed you. Homogeneous intense enhancement, very useful for the differential diagnosis. Don't be scared of getting a contrast. And these things are internal flow void because are serpiginous areas of hypointensity. That's a very easy case, very common mass. So tell me, what is the diagnosis?
So, A, infantile hemangioma, B, venous malformation, C, venolymphatic malformation, D, AVM.
And while you vote, these are the 4 main pathologies that we found in the infant. And, apart from rhabdomyosarcoma, these are among the most common. So once you will, I will stress the element of differential diagnosis between them. You have done most of the job. Apart from very, very rare cases, you would not be finding, you will not be really fooled by very strange stuff, unless you are very unlucky, once you know the element of radiological differential diagnosis between these 4.
Okay, so most people voted for infantile hemangioma, 73%.
Yeah, so the only other difference, 20%, is venolymphatic malformation. I will show you what are the elements of differential diagnosis. This was an infantile hemangioma. So remember, the key feature is, first of all, this is a benign mass. And these are radiological features, they are clinical features I will show you in a bit. But the enhancement is homogeneous because this is a neoplasm. It's a vascular neoplasm, it's not a vascular malformation. So this is a neoplasm, homogeneous enhancement, apart from all these internal vessels that are the radiological hallmarks of the infantile hemangioma. Although you can have some pitfalls. There are no calcification, and remember, most of the infantile of the hemangiomas, so the so-called infantile hemangioma, because then we have the congenital hemangioma, but most of them are infantile hemangioma, and they go toward a triphasic evolution with final involuting phase of fatty replacement. So ask your clinician how the lesion is behaving. It's completely different from the venous and venolymphatic malformation. The first differential diagnosis is another T2 bright mass. So this is a mass, so you always see the mass, you should give contrast. And again, we have some areas of hypointensity here and maybe some stripes here, okay? So again, we have the area of hypointensity. In this case, we were very lucky because we had also the ultrasound with this shadowing. So now I will ask you, what is this thing inside?
So A, flow void, B, calcium, phlebolith, C, blood, D, nidus, AVM.
So these are all things that can be hypointense in T2, flavoid, the nodus of vessel in the AVM, a clot of blood, and calcium. So, but in this context, and also remember, where is the lesion? This is in the masticator space. This lesion like masticator space a lot. This lesion is centered in the masseter, but it is basically there. And almost all of you got it right. Most of you probably also because they know the ultrasound. And this is typical of calcium. But what is important that as the flavoid, internal flavoid are the typical radiological hallmarks of the hemangioma, the flavolites, although not always present, are the typical radiological hallmark of the venous malformation. That is your first diagnosis. And the important thing is that because this is a malformation, right? It's not a tumor, the enhancement is variable and increases over time and is patchy and heterogeneous. So if you read the book, and then every one of us, we study something in the book, and then in the practical, clinical, daily experience, we stress other things that are not very maybe stressed or focused on in literature. But what I learned is that I don't trust too much this T2 signal that is supposed to be very, very bright in venous malformation. I trust the presence of flavolate, absence of flavoid, and variable enhancement. There can be some stripes, there can be fibrous tissue, but that's not like serpiginous flavoid like in the hemangioma. Look at this other scan. And this is the importance of the clinical appearance. We just had these two sequences. Again, T2 coronal, fat saturated, and T1, remember, pre-contrast, you need the fat around, so you don't fat saturate the T1 in the head and neck. So this is a female right cheek vascular malformation. This is all we got. What are these things? Are vessel or are stripes of fibrosis with a few flavolites? It's a bit difficult, right? Maybe flavolites or maybe vessels. But what you remember that you can take the phone and call your clinician. This was a mass. It was flesh color bluish that expanded after Valsalva maneuver and could be flattened. So this is a mass that changed with venous pressure. This is critical because, of course, this is typical of what?
Of
Infantile hemangioma, venous malformation, venolymphatic malformation, or AVM.
Okay, I think most people will get it. So I'm ending the poll here, share the results. So most people said venous, but what about venolymphatic? How do we differentiate?
That's very important. So I will show you a paper that you must download really from Deborah Schatkes, describing the difference between venolymphatic, between malformation and tumor, vascular tumor. But the important thing you need to remember is that, so this was a venous malformation. The malformation, vascular malformation of the head and neck region can be simple or complex. So if they are complex, they can have venous element and lymphatic element, for instance. But the important is that the lymphatic malformation is full of cyst and have fluid level, with the vascular element giving you some contrast, so patchy areas of contrast. But if you say something that looks like a venous malformation but is mainly solid, you call it venous malformation. If you see something that looks like a lymphatic malformation but has some contrast, and again, you read the book and the book say lymphatic malformation, no contrast, but you can have some venous leak that enhances. So in this case, you can look called venolymphatic. The reality is that in this case, and I will show you cases where it matters, the differential. In this case, venous malformation of venolymphatic doesn't change because they do sclerotherapy and they are fine. So the management is very, very similar. But remember, venolymphatic malformation are mainly lymphatic with some veins, according to my experience. Look at this other. Same location, post-contrast, fat-saturated images. Look at the enhancement here. Look at the difference with the hemangioma. So my pearl is I trust the patchy and increasing over time enhancement more than the T2 signal to differentiate hemangioma from venous malformation. If you read the book, they say very, very bright in T2 venous malformation, a bit less bright in T2 hemangioma, but really, really you need to kind of use the contrast more. And also ask your clinician what the lesion look like. This is how the lesion look like, is bluish, and this is how the hemangioma look like. So venous malformation, hemangioma. Look at the trajectory of the hemangioma, increases and then fatty replacement. And if you look at the this is a beautiful book, just a differential diagnosis in pediatric dermatology. Look at this hemangioma, increases over time and then disappear. The venous malformation are always present at birth, while most of the hemangioma, they need a bit to develop. Although there are congenital hemangiomas, but the infantile hemangioma regresses, the venous malformation goes worse and worse, need to be treated. So this differential diagnosis is very important. The differential diagnosis between venous malformation, venous lymphatic malformation, not really important. Look at this other case. So it came with a reddish color here, sometimes swelling. We had the genetic diagnosis, so we knew what we were dealing with, but that's very complex case. Look at this area of enhancement here, and look at the TOF. There are prominent vessels. So I showed you before, prominent vessel is a characteristic of the hemangioma. But of course, when it comes to prominent vessel, you need to consider also AVM. In this case, the TOF was not enough to show the nidus. So is this a micro AVMs that is too small to see the nidus, or these are flow voids that show some enhancement? Sorry, there is a poll that started.
Yeah. Oh,
Yeah.
am I too early?
Wrong.
What is the arrow pointing
Yeah.
at?
Yeah. So, okay. So, or, you know, this is, let's say, the flow void, that the vessel that is characterizing the hemangioma. So I also put something else. So tumoral cells with arterial feeders, phlebolytes, blood, or a nidus or AVM. What's the difference? Of course, tumoral cell meaning hemangioma. So in this case, you say a nidus or AVM, but remember why you say that. So the problem is that these were micro AVMs, and we knew that because we had the genetic diagnosis that was a RASA1 mutation that is associated with AVM. And we had this prominent maxillary artery and arterial artery, and then we did an angiography, and we demonstrated that at that level there were some niduses. But we knew that this was RASA1 mutation, and see also the prominence of the soft tissue in the left side of the face. So we knew already that this had to be an AVM. But my point for the differential diagnosis, and I will show you several examples now, is that prominent vessels are characteristic of AVM and hemangioma. The difference is that the hemangioma has a mass. The AVM, look at that. Where is the mass? This is just a bit of contrast. There is no mass whatsoever. And this is why you need to work out your differential. This is another case where the differential is critical. Why? Because AVM goes worse and worse, a very difficult aesthetic problem for the child. They can lose the eyes close to the orbital region and so on. And hemangioma can be close to the orbital region, regresses as the one I showed you before, and it's not a problem. So first differential diagnosis, the second differential diagnosis is AVM. We know what is an arteriovenous malformation, but remember, the only very important thing is that you see the nidus, but you can sometimes in the macro AVM, you cannot see the nidus clearly, but there will be no mass. Another thing, the AVM can be very aggressive, can erode the bone, but again, there will be no mass, and this will help you in differentiating from aggressive masses like the rhabdomyosarcoma. So mass and flow void hemangioma, mass and phlebolite venous malformation, mass with a lot of cystic component, a bit of patch enhancement, venous lymphatic malformation, no mass, a lot of vessel, AVM, right? Look at this other case. This case is full of vessels and also enlarged veins, and we did also an MRI that can show that some of these vessels have arterial flow. Okay. Now, what is the diagnosis in this case? So remember what I told you, and try to do work out the differential. I don't know if you have any comment while people are voting, Ali.
Oh, no, I think it looks good. It's very important that for the AVM, I see many times people are confused if that's an hemangioma or AVM. The key finding is there is no mass in AVM. So that's really important. Yes. Okay, so for this case, that's interesting because most people said hemangioma, but there are also people calling this an AVM.
I cannot see
Oh,
the
sorry,
result.
sorry.
Oh, yeah.
Okay,
Okay.
that's
Oh,
sharing.
very good. So this is actually 30, 30, 30. So 40% say hemangioma, 25 venolymphatic malformation. But I told you venolymphatic malformation is full of cystic areas, and 35% saying AVM. Okay, this is very nasty looking, full of vessel, but this is a mass, guy. You know, that's a mass. When you see a mass, first of all, you call the clinician, because if you have a mass, they will have a clinical appearance that can help you a lot. Second of all, you look at this vessel, you know, all this vessel, if there was a shunt, should have given you something in the sinus. There was no shunt whatsoever. But your point is that a mass? Yes, full of vessel, we don't care, okay? So this was a rapidly involuting congenital hemangioma on the forehead. So remember, mass and flovoid hemangioma. If you have any doubt, you call the clinician. No mass, a lot of vessel, think AVM. Look at this case. 1-year-old male, right proptosis here. Okay, so look at this. Again, we have a problem with the proptosis. So there is an aesthetical problem, something, you know, creating a problem in the eye with a lot of vessel. This is the post-contrast, this is the T2, then they fat saturated T2. For some reason, they fat saturated also the T1, but still in this case, you can see better the vessel in the fat saturated T1. So now I have a look at this image like for 5 seconds, very, very important. I want to thank the family that gave me this case because I think that that's very, very a nice case. So think about what we speak with Ali, and tell me again, same differential: hemangioma, venous malformation, venolymphatic malformation on ABM.
Okay, people are voting. Okay, stopping the poll now. Share the results. So most people said AVM.
Good. Okay. So in this case, that's very, very good that you say ABM, because again, where is the mass? Where is the enhancement? There is mass effect because of the prominence of the vessel, probably the blood and the venous drainage is here of the superior ophthalmic vein is impaired. So we have this proptosis, but where is the mass? There is no mass, guys. So this is too many vessels, no mass, worsening over time is an AVM. This is a red flag because they thought that this was an hemangioma. They biopsied the eye and they found only fat. They thought that they got the biopsy wrong. They treated with propranolol. The child was worse and worse. And before they figure out that was an AVM, there were a lot of problems in terms of aesthetics of the face. They need to go in another center, embolize. It was terrible. So this became a medical legal case. You need to be aware. First, give contrast, and second, you need to be aware that if there is no mass, at least think, say, listen, this is very small. I see some vessel, but think of AVM in the differential. Speak with the neurointerventionist. Right? Very important. Look at this other case. That's another situation when there are a lot of vessels. The problem is that whatever is going on here is centered in the parotid, that is per se a mass. So now we have a problem. And if we do MRA, we see again prominent vessel, arterial vessel, also in the MRA. So again, you have a conundrum here. You have a lot of vessels, and you need to decide whether or not there is a mass or not, or this is just the parotid, and this is an AVM within the parotid. The lesion look like that. Now let's go with the, so remember what I showed you before, remember what I described also without showing you. So this is what it was. What do you think about that? It's an hemangioma, it's a venous malformation, lymphatic malformation, or AVM. And if you think I'm going too fast because I try to reach the end of the talk, but just chat or text Ali, and I will just slow down. It's okay.
Sure. Results.
Okay, almost everyone say hemangioma. Very, very, very good. Why? Because if we come back here, you see the parotid stops here. This is all mass. You see the mass, you see the vessel, and it looks like an hemangioma. Think about hemangioma, all right? Non-idus, typical appearance here. There is a mass and responding to propranolol. So this non-idus actually was the fellow. I changed this. This is mass, not non-idus. Sorry about that. This is an old presentation, old slide, but remember there is actually mass. So this is a slide from Deborah Schatkes. She worked in US. She's an expert in vascular malformation. So there are things that enhance and things that do not enhance. The things that enhance are masses and are hemangioma and venous malformation. Phlebolytes, venous malformation, you can see the sigma in T2, although I don't trust too much. Dynamic patchy enhancement. Enhancement with triphasic growth and this internal vessel, intermediate sigma in T2, again a mass, this is hemangioma. Different appearance, different evolution, clinical evolution over time. Now, without mass, but with a lot of vessels is an AVM. Remember, AVM can be aggressive. So when you see bony erosion, you need to think of an AVM. Lymphatic malformation can be macro, microcystic. I will show some example, but remember the radiological marker. So what you focus your attention to among all the things we see, in this case, is fluid level because of the internal bleeding. So here would be the phlovoids, here will be the phlebolytes, here will be phlovoids, no mass, here fluid level. And this is the paper I want to suggest. It's a very short paper, very well written by Deborah Schatkes, and explain you the combined malformation, for instance, veno-lymphatic malformation. So venous malformation plus lymphatic malformation, and also syndromic association. Now look at this case with a lot of bony erosion. So now we have a mass, again centered in the masticator space, like the venous malformation I showed you before. There is some bony erosion, and this is the appearance on DWI, this is the appearance on PET. Again, there are areas of T2 hypointensity within. Now you need to decide what are these areas and how we interpret that. That's very, very easy for you. So what is this? Hemangioma, rhabdomyosarcoma, veno-lymphatic malformation, or AVM with bony erosion. Okay, 74 said rhabdomyosarcoma. Some of you say veno-lymphatic malformation, 23%. Okay, so this is a diagnosis you need to get right. So it's very important that you understand that this is a rhabdomyosarcoma. Why? Let me come back, guys. So this is a mass, so cannot be an AVM. These areas are necrosis. They do not look like phlebolytes, but they may be phlebolytes, but remember that for sure they are not vessels. But remember, venous malformation, veno-lymphatic malformation can be transspatial, but they are not aggressive. They can also be in the bone, but you will not have this erosion. You will not have diffusion restriction, and for sure this is an aggressive PET profile. So if you see a mass aggressive in children, especially if it's centered in the masticator space, think rhabdomyosarcoma. They can be everywhere, but again, as venous malformation, they have predilection in the masticator space. The difference being that they are very aggressive in their behavior. All right. So when you see something like that, call rhabdomyosarcoma until otherwise proven. On top of that, you have the age that helps you, because as I told you before, they are born with venous malformation. They have this bluish color, change with Valsalva. Rhabdomyosarcoma, they develop over time. And remember, bony erosion, aggressive invasion of surrounding soft tissue, and areas of necrosis. Diffusion restriction has been reported, although they are intermediate, they are not as much as the embryonal tumor, but for sure much more than the venous malformation. So aggressiveness, mass, child, rhabdomyosarcoma is your first differential. Now, these were solid mass. Let's go to the cystic mass. Now, one thing I want you to remember is that when it comes to cystic mass, they look all the same, okay? They are full of fluid and do not enhance apart a bit of rim here. So for cystic mass, everything is about location, location, location. So when it comes to cystic mass, you think about location. So look at this mass, where it is, and how you would describe. So I described already, this is fluid, and where it is, well, is in the midline, very close to the strap muscles. Okay, so what is that? What do you think it is? It's very easy. If someone wants to write in the chat, we don't have the chat though. Yeah.
Oh, we
What
do have the chat or the
Oh, I think
Q&A.
only
Yeah.
Q&A. Anyway,
No, both.
but I didn't realize there was the pool. So what is that? First branchial cleft cyst or anomaly, second. Okay, everyone say thyroglostal duct cyst. Very well, because it's a cyst and the cysts look all the same and is in the midline. Now, I think the pool we shall repeat the same pool afterwards. Look at this other case. It looks exactly the same, but slightly in different position. Note the relationship again with the strap muscle, but this is not on the midline as before. This is probably a partial voluming effect. We call it non-enhancing or just with a rim enhancement, sometimes a bit prominent. Remember that every cyst can be infected or can have rarely the neoplastic degeneration, but this I think was not the case. Okay, so what is that?
Yeah, okay.
Let's start with the same pool as before,
Okay,
please.
yeah,
The first
sure.
branchial cleft cyst, second branchial cleft cyst is a small venolymphatic malformation or another thyroglossal duct cyst. So same question as before. Think about, you know, what I described and try to think what can be. Okay, very interesting. So most of you said second branchial cleft cyst. This was a pitfall, okay? Some of you say first branchial cleft cyst. So I told you location, location, location is very important. So you need to know where the cyst, the first branchial apparatus anomaly, the second branchial apparatus anomaly are expected, and where the thyroglossal duct cyst is expected. So this was another thyroglossal duct cyst. Why? Because they are median. Again, what we read in the book is median, but they could be also paramedian. And these things was confirmed on pathology as thyroglossal duct cyst. The second and first branchial cleft anomaly will never be there, but all the thyroglossal duct cysts have this very close relationship with the strap muscle. So remember, this is from Ansberger. They say it could be paramedian, especially in the infrahyoid neck. Remember the course, and actually I put in my YouTube channel a short lecture that I did for the European course of neuroradiology on the embryology of the neck. It's a practical embryology, just to help you to realize where the lesions are from. It's 20 minutes. And I think once you read it, you see this. And because I studied for that, I didn't know all these things. I studied for this presentation, and a lot of things become clear. Speaking about midline cysts, you need to know element of differential diagnosis. This is a slide courtesy from Callie Robson, who is the pediatric neuroradiologist, one of the pediatric neuroradiologists at Boston Children. Look at this cyst. Posterior third of the tongue, anterior third of the tongue or tubular, and this is down the tongue but with restriction. So this is a vallecular cyst. Vallecular cyst is very similar to the some location of thyroglossal duct cyst up in the base of the tongue, but is in the base of the tongue, so it's posterior. If you see a cyst in the tongue that is in the anterior third of the tongue here, or rarely can be serpiginous, think of foregut duplication cyst. Very, very important differential, because also the management, surgical management is a bit different. If you see a cyst that shows restriction, call it, well, I would call it epidermoid/dermoid cyst, because they can be very similar. It's not true that restriction is only dermoid. And also pathologically, it doesn't make much sense to distinguish the two. So I report epidermoid/dermoid cyst. But this difference, posterior tongue, anterior tongue, vallecular, or pteroglossal duct cyst, and for a good application is very, very important. So remember, location, 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 pteroglossal duct cyst is between the foramen cecum and the hyoid bone, vallecular cyst in the vallecula, and they are both posterior in the tongue. When the pteroglossal duct cyst happen in the tongue, as you saw, can be also down the neck. But foregut duplication cyst is in the 1/3 of the tongue or serpiginous. So remember this location for the differential. And this is a beautiful paper from the group in Boston, where they say foregut duplication cyst of the head and neck, although uncommon, should be included in the differential diagnosis of cystic head and neck lesion. And remember, where is the vallecula here and where is the foramen cecum? Sometimes you cannot really distinguish when the cyst is big. Now, there is another cyst exactly like the other one in terms of signal, just there is a bit of tract here and is in a different location. So, what's that? Is the first branchial cleft anomaly, second branchial cleft anomaly, veno-lymphatic malformation, or a lateral pteroglossal duct cyst? Think where is the lesion? Again, if I'm going too fast, just chat and say, sorry, go slower. Okay, so most of you say first branchial cleft anomaly. The correct terms now is branchial apparatus anomaly. Some of you say second branchial apparatus anomaly, 25%. No one say pteroglossal duct cyst, very well. Just 1% say veno-lymphatic malformation, very well. So this is a first branchial cleft. Branchial apparatus anomaly are first, second, third, and fourth. Most of these are second branchial cleft, so you need to know how to diagnose the second branchial apparatus anomaly. The rest, you can live without. They are very rare. But the first branchial apparatus anomaly can be either inferiorly to the auricle or, like the case I showed before, along the lateral margin of the parotid. So even if you don't see a tract that we could see in that case, remember the embryological course, and you will have the diagnosis. The radiological characteristic in case of cyst do not help you. And this is the one below the auricles that I took from SlideShare because we didn't have a case at Gosh. This is another case, a cyst. CT appearance is still a cyst, no enhancement, nothing. Now, my question for you is, and you can use the chat if you want, or Ali can do the diagnosis, what are the 3 anatomical boundaries of the lesion? 1, 2, and 3. What are these anatomical boundaries? Feel free to use the Q&A session just to write, or Ali, you can say something if you want.
Okay, so in the medial aspect, I see the carotid and the internal jugular vein.
Yeah, so that's a carotid space indeed.
Carotid space. And posteriorly, I can see the sternocleidomastoid muscle, I guess.
Very good anatomy.
And anteriorly, is that the submandibular gland?
Correct, exactly what should be. So basically, you have done, because location is like the real estate market when it comes to cyst differential diagnosis in the neck. Location is everything. So you have done the diagnosis because our point of interest, the flat we want to buy, is exactly where we want it to be, between the submandibular gland, carotid space, and sternocleidomastoid muscle. So this is a second branchial cleft anomaly, typical location. Now look at this other case. This is an MRI. Again, the cyst looks exactly like the other. Look at this, think where is located this lesion and how we are going to do the differential diagnosis. So look at this, where it's located, and try to do the diagnosis. Other 3 seconds. What is the diagnosis? First branchial apparatus anomaly, second branchial apparatus anomalies, veno-lymphatic malformation, or a pteroglossal duct cyst.
Okay.
Very, very good. Again, every one of you got it right because Ali described precisely the location, which is between the submandibular gland, carotid space, and sternocleidomastoid. Is at the level of the anterior medially to the superior third of the sternocleidomastoid. So that's very, very important. Now, We know how to do the diagnosis of second branchial cleft anomaly. We are done. The other are very rare, but still, I want to show you. This came as lymphatic malformation, but this is in this fatty space that is the posterior cervical space with a tract going there. So we reported this as a third branchial apparatus anomaly because the book said that when it's in the posterior cervical space, we call it third branchial apparatus anomaly. This is controversial. So I don't have the histological diagnosis, but this is how I reported because this is from Bernardine Koch. This called, you see, fat posterior cervical space, third branchial cleft anomaly. So is below and is medially to the middle third of the sternocleidomastoid. Okay. This was also, on the right hand side. Anyway, I will come back to that. But as a general rule, if you call it third branchial cleft anomaly or apparatus anomaly assist in the posterior space, you are correct. Look at this other thing. The arrows are pointing to two structures on the normal side. This is on the left. There is a tract connecting these two structures. Now, think about what these two structures, what they are. You can use the chat, or Ali can do a brilliant diagnosis. So what is that structure?
That's the thyroid gland.
Yes, correct.
Yep.
This is exactly the thyroid gland. And what is this structure full of hair here? Probably I didn't give you the best thing, but this is piriform sinus. So on the other side, we have a tract connecting the piriform sinus to the thyroid lobe. And this is what we call four branchial cleft anomaly. That is not a cyst, it's just a tract. And this is a case from literature, again from Bernardine Koch, and you can see that they gave contrast barium, and there is this tract connecting the thyroid to the piriform sinus, and both are on the left. Now, it's all about location, but it's also about embryology. And I want to show you something. This is a simple lecture just to guide you through the differential diagnosis, but things can be a bit more complicated. This is an amazing paper from Bijoy Thomas. And Bijoy also has a YouTube channel for 10 minutes differential diagnosis. He does mainly adult now, but this is when he was in Toronto, where Ali and me were just 10 years earlier. And they described this, what they reported as third and fourth branchial apparatus anomaly, and none of these follow the classic theoretic pathway of the third and fourth arch remnant. So probably the embryologists say these things are from the embryonal thymopharyngeal duct of the third branchial pouch. Again, if you want to know what branchial pouch is, arch, fourth arch are, just look at this short YouTube video on the embryology and everything will be clear. But it's just to say that there are some controversy, and sometimes we study, but then what people have been reporting on literature for years and years may be not correct. So keep an open mind. Anyway, for your report, if you call it third branchial apparatus or fourth branchial apparatus anomaly with the location I told you, you are not wrong. One thing is very important, guys, is that they are often on the left, and the so-called fourth branchial apparatus present with infection. So sometimes you have soft tissue. I forgot to add the case, but I have a case of soft tissue in this location with a small tract barely visible. So you can call it a tumor, you can call it an infection, but actually look for the tract whenever you see on the left side of a young child soft tissue inflammation going on between the piriform sinus and the thyroid lobe. Very, very important. Now, other few cases, and in the next 10 minutes, so this is a large mass, again, location. Where is it? Everywhere. Transspatial location. What are these things here? Look at the different intensity, a bit different from before, okay? So what's the diagnosis? Very, very easy. First branchial, second branchial cleft anomaly, veno-lymphatic malformation or lymphatic malformation, because there is not much different, apart from a bit of contrast in the venous malformation, or a thyroglossal duct cyst. No one believes in the thyroglossal duct cyst anymore. You saw the fluid level, transspatial. This is a veno-lymphatic malformation. Very, very easy. Why? Because the radiological hallmark of the venolymphatic malformation are fluid level. Most of you know that. What about this other transfacial cystic lesion? Look at that. Can you see where it goes? You have the subcutaneous soft tissue along the temporalis, in the orbit, masticator space, the pterygoid fossa. So same question though, another transfacial cystic, but very different from before. Is this a first branchial cleft cyst, a second branchial cleft cyst, venolymphatic malformation, or pteroglossal duct cyst? Or something else? Maybe I...
Felice, we forgot to disclose a heavy Turkish accent and a heavy Italian accent, right?
Oh yes. What
Yeah.
are you? I thought that I speak like someone from Kent. What are you speaking about?
But
My,
I prefer Italian accent to British accent. It's easier for me to understand.
oh yes, yes, that's true. Yeah, try to go to Birmingham. All right. Yes, venolymphatic malformation, 95%. Why? Because venolymphatic malformation can be macro and microcystic. So again, remember also that they are treated with sclerotherapy and they can change over time and become microcystic. So it's very, very important. Can be rarely uniloculated, but most of the time multiloculated, non-enhancing cystic landmass, transfacial fluid level. So this is the radiological hallmarks. And if you have this to answer the question that often I receive, combine elements of venous malformation, lymphatic malformation, so a bit of context enhancement, think of venolymphatic malformation, doesn't change much in the management. So again, lymphatic malformation, macro and microcystic, hemorrhagic fluid level. Let me show you this other fluid level. So tell me, what is the diagnosis? Really, guys, I think you can chart it. So this is another fluid level, another mass in the head and neck region, but in this case, it's just one cyst only. So think if you know what this can be. Ali, do you want to comment a bit on that? Where location? Oh, someone is chatting. Good.
Yeah, we have an answer from people AKK and
I don't know what is.
Mucosil. What is AKK, Shukriya? Can you type it like openly? Mucosil for the location, I think because it's in the sinuses, they call it a mucosil.
Yeah.
But there is definitely a fluid level
because
it's T2 dark. I think it could be hemorrhagic. I don't know.
Yeah, I mean, so mucosil location is fine for mucosil, but fluid level is not.
Oh,
really.
aneurysmal bone cyst.
Well, that's interesting. Two people say aneurysmal bone cyst. Well, it's again location. So look at the CT. This is not transfacial. This is centered in the bone. So it's just to show, and Sucrier and Gokalp, they got it right. Very good. This is an aneurysmal bone cyst. Remember, the fluid level is the radiological hallmarks of the lymphatic malformation and aneurysmal bone cyst. So if something is centered in the bone, think aneurysmal bone cyst. Transfacial in the neck, easy diagnosis. Everyone got it right, lymphatic malformation. Now, this is very, very easy. Again, big mass with a lot of cyst, but also solid component. This is post-contrast fat SAT. This is a T2 fat SAT. And how you describe this? Is this a dermoid, a teratoma, Aeropolip, or sarcoma? It's quite big. It's a neonate congenital mass. Remember, the age is very, very important, together with location. And in this case, it's solidocystic, so you need to use also the appearances. Okay, so 70% say teratoma. Some of you say the sarcoma or dermoid. I told you sarcoma, you can have, a congenital sarcoma, but a pseudocystic mass in a neonate is most likely to be a teratoma. Now, the important thing is that you need, again, technical knowledge of the difference between head and neck radiology and brain radiology or body radiology. You need the non-fat saturated T1 pre, because when you see fat, and this is an easy case, but sometimes when the cysts are a lot, you can think that this is a lymphatic malformation. We had some cases of lymphatic malformation, what we call lymphatic malformation, and then develop some solid areas very fast, but the clue was in the fat. So remember, look for the T1 spontaneous hyperintensity of the fat, okay? And this is, remember that these are emergency because, there is a displacement and compression of the airways. So teratoma, anterior neck of midline, there is fat. You can have the main differential is lymphatic malformation. Goiter is also differential because they may arise from the thyroid gland. But most of the time, we had just one case of teratoma in the orbit that simulated lymphatic malformation because it was mainly cystic. But if you see a lot of solid part, think teratoma first and look for the fat. This is the last case for today. This is another emergency because there is a stenosis of the airways. And look at this mass. So think how this look like. So there is this hypodense mass with hyperdense center. Okay, so this density here is very peculiar and very similar to density here of the parapharyngeal region. So this is probably fat. But look at this structure, and this is how it looked like. So it was operated. Look at the fat and the central stalk of fibrosis. So again, what is your diagnosis and why? It's a dermoid because of the fat. It's a teratoma because of the fat, and despite we don't see, maybe it's a more mature teratoma. It's an Aeropolip, so it's a polyp that develop in the infant, or this is a sarcoma that does not show the aggressiveness that we expect. So remember, lesion in the nasopharynx, mainly fat, but with some hyperdensity in it. Okay, that's very interesting. So 44% say dermoid because when we see a fat lesion in the head and neck region, we think dermoid. 20% say teratoma because, as I showed before, there is teratoma, but this thing in the middle may be a soil speck. 35%, so close call with dermoid, say Aeropolip, and no one believed the sarcoma. That's very good because these are benign lesions. So this was called a dermoid from some people and teratoma from other people, but it's actually an Aeropolip. This is pathognomonic appearance of the Aeropolip is a polyp made of fat with a stalk of fibrous tissue in the middle. So you know your histopathology and you will connect with your radiological appearance. And most of them, not all of them, they arise from the Eustachian tube, but they are typical lesion in the nasopharynx. And look again, fat, and the fibrovascular stalk. So my pearl is know the histology, you will guess your diagnosis. So this is a pathognomonic appearance. So the tips of the day is that you think cystic, and when it's cystic, you go for location or solid. So the first thing you ask yourself is cystic or solid or mixed. If it's cystic, you think about the location and your embryology. If it's solid, look at the characteristic, the radiological hallmarks. Use the right protocol. T2, you need to get rid of the fat. T1, pre without fat suppression, post with fat suppression, because if you have a tumor, it will enhance, and you don't want the confusion with the brightness of the fat. Keep looking, and if you have a problem, ask a friend. There are a lot of experienced people around, and just feel free to send an email and so on. So I will stop sharing, and I will be happy to take some question, not in Turkish unless Ali.
Sure, I will translate you. Thanks. So we have a question from this is Dr. Zeynep Yazıcı from Bursa, and she is asking is it necessary to confirm the diagnosis of pyriform sinus fistula with an esophagography?
No. What normally not. So the problem is that these children are scanned for inflammation, and the point is that this was an old case from Bernadette that clearly showed the connection. But most of the cases, the pitfall when it comes to so-called from branchial apparatus anomaly is that you have a mass there, and ultrasonographists 2 days ago called it a tumor. And because of the location of between the piriform thyroid and the thyroid, you need to look for the tract, but the MRI is enough, and sometimes the ultrasound is enough. I would never give barium to be fair, but it's important you just do not say it's just an inflammation, because then if we don't treat the tract, it will recur.
Yes.
Okay.
Yeah, so we started the question session, questions and answers. Feel free to ask questions, and we
Yes.
have time.
Yeah. Another thing, yeah, I want to stress is that it's really in some of the situations we never do MRI. Like thyroglossal duct cyst is very, very unlikely that we do an MRI. But you know, the ultrasound is the most important thing that we do for some of them. But in general, I think if you start, you know, with cystic solid and then go from there, it's very, very easy. It's much easier than the adult head and neck, where you need to track down the tumor and so on. There is another question.
Yeah, another question from Sarhat Akış. Does it matter with respect to management, the differentiation between the first and second branchial cleft cyst?
Not that I know of. It is important sometimes, the differentiation with the foregut duplication cyst, but it's just and with lymphatic malformation. But between first and branchial, I don't think they changed the management. But it's like some tumor, you know. Uh, we like to do you know, to differentiate that, because we understand the embryology, and when we understand the embryology, we understand better differential diagnosis. When we used to, there is a, you know, a paper that we publish just out on AJNR. We try to work out a flow chart for differential diagnosis of posterior fossa tumor in children with Cesar Alves in Children's Hospital of Philadelphia. Does it matter? Well, for now, not really, but they start to add a lot of things in the medulloblastoma classification and can change the prognosis and so on and so on. So the more we try to understand also the embryological controversies, the more we know, and at some point this may matter. So it's good to do the right diagnosis if you can, but between first and branchial cleft anomaly, I think they treat exactly the same. Foregut duplication, they do slightly different operation in comparison to a thyroglossal duct cyst or vallecular cyst.
Thank you. I think that was clear. Another question, how can we differentiate multi-compartmental second branchial cleft cyst and lymphangioma without fluid level?
Okay, so first of all, we don't call it lymphangioma anymore, we call it lymphatic malformation. That's very important, because lymphangioma as name implies that this is a tumor, while venous malformation, lymphatic malformation, AVM, they are malformation, while hemangioma is a tumor. The multi-compartmental branchial cleft cyst, it is very rare. You can see a tract, and sometimes you can see a small cyst and tract better, but normally we tend to have transspatial lymphatic malformation and single locate, you know, a single cyst or sister tract located in the space that Ali described. Sometimes you have very weird stuff you cannot distinguish, but I mean, I never encountered these things. The thing that I encountered, as I said, is teratoma, cystic teratoma versus lymphatic malformation can be very tricky and changes a lot. So yeah, I will add this case to the presentation next time. Very, very, I cannot, because there are, you know, there is no consensus.
Another question by Dr. Oktay Zaim. He is asking, what is the differential diagnosis for the sublingual herniation? Or sublingual herniation?
I've never seen a sublingual herniation in my life.
Okay.
So I
Me
don't know.
neither. I don't know. Maybe if
I think
he can.
sublingual gland herniation, I think, but I've never seen one. So I'm not. I mean, I
Maybe,
think.
yeah, if he can join us, or he can just
Yeah,
explain
very happy to.
more.
I mean, so there is the sublingual gland herniation through the malleoid gap, but I I don't think this is
Yeah.
really, yeah.
Felice, I started to see lots of ectopic thymus tissue in the neck, and it's sometimes very confusing and sometimes associated with a thymopharyngeal duct cyst. So, look, would you like to make a comment?
Yeah, but are you sure that it's thymus and not thyroid, right? Ectopic thyroid.
Yeah, yeah, thymus, yeah.
Yeah, so the problem is, again, if the thymus and also the ectopic thyroid, they are solid masses, okay? They can have both of them, some connection because embryologically they derive from duct. So the best example is that if you see, you know, the ectopic thyroid is along the course of thyropharyngeal duct, and they can be associated with the duct. So it's very, very tricky to do the differential, but you can say that this is solid, and then there is no real, you know, when you are sure about with ultrasound, basically about the fact that this is not aggressive tumor, you are more or less okay. And then you follow up and you see the evolution over time. So the regression, for instance, over time, and the thyroid, the ectopic thyroid, they can have hormonal problem and so on. But the important thing is that you are not fooled about, you know, that this is a tract with a neoplastic malformation. So you need to check the ultra structure of the thing. But this is better done on ultrasound. So when you know, you check the thymus and thyroid is better done on ultrasound. So I think yeah, and they are very uncommon, especially the thyroid. I've seen a couple. But again, they follow the thing, because if you know the embryology, the thyroid starts to develop from the thyrocostal duct cyst and then goes down. Very, very interesting.
Yeah. They're asking about ranula, actually. I think he meant ranula.
Yeah, ranula. Yeah, so very interesting. The diving ranula is basically like a fluid ranula. They open up and they involve the submandibular space, and there has this comet shape. The important thing, and that's a very good question, I didn't have time to show the example, but radiologically, you cannot distinguish between ranula and a lymphatic malformation in the sublingual and the submandibular space. They look very similar. So my take is that if I see a fluid level, I call it lymphatic malformation. If I see only cyst, I say favor ranula cannot exclude venous lymphatic malformation. Not sure, to be honest with you, what's the difference in terms. I think that if it's a cyst, they take it out, while lymphatic malformation, they can use sclerotherapy. I'm not sure it's changed the management, but I'm sure that radiologically without fluid level, very tricky differential.
Yeah, they look same. Yeah. And okay, let me check the questions. There is one more question. So in the adult world, when there is a cyst, we need to consider cystic lymphadenopathies, but is it the same for children? Is it in the differential diagnosis of cystic lesions?
Well, no, I never came across, you know, a cystic lymphadenopathy, which is not a necrotic kind of evolution of tumor or sometimes tuberculosis and so on. The difference with when it comes to nodes is a bit more that people from the adult world, I mean, normally they are not neuroradiologists or head and neck radiologists, but they call the nodes that are quite big in children, they call it as mass or something. But you know, remember that the nodes in children are a bit enlarged. But this cystic lymphadenopathy, I haven't encountered in my practice. At least I do only cross-sectional images, so I don't not sure about the body colleagues, pediatric radiologists. I don't know, Ali, what's your experience about that? But not very frequent for me.
Yeah, I think there is a difference between children and adults for the lymph nodes. In adults, if you see a cystic lymph node, then it's necrotic and it's more likely to be a metastatic lesion. But in children, we see atypical lymph nodes all the time. They may lose their echogenic hyla. They may be rounded. They may be really hypoechoic or sometimes cystic, even with a simple infection. They don't have to be malignant. So in children, it is different than the adults. They don't have to be lymphoma, you know.
Yeah, but the bottom line is, you know, I think I trust ultrasound, and we should not ask too many MRI for things that can be explored in ultrasound. MRI is the second step, and this is why I show you the differential that I work on. But most of you guys do a lot, most of the job in terms of first differential technology. So this is very, very important to know where our expertise stops. And this is why we don't see many pteroglossal duct cysts, because we don't image them. They are one thing I wanted to stress, again, I didn't have time. When you see a solid cyst, a solid lesion in the skull or skull base, the first things to do with restriction and so on, some people call SCH, some people call rhabdomyosarcoma. The first thing to do, you do an ultrasound of the abdomen, because most likely is in an infant, this is a neuroblastoma metastatic in the skull and skull base. So this is something I have in a lot of my lecture. In this case, I didn't put for a question of time, but remember that if you have a solid aggressive lesion in the skull base or skull in an infant, the first thing you ask before biopsy and all the stuff is an ultrasound of the abdomen, because you can save a lot of hassle to the child. So remember, much more frequent than nodal or intracranial metastasis are the skull metastasis from neuroblastoma.
Okay, let me read you this question. In the late phase dynamic post-contrast images, do venous malformation enhances completely eventually, so indistinguishable from other solid lesions?
No, in my experience, they are always patchy because there are always some, these are histologically some large venous lake. So there will be at least some phlebolites here and there to create. But normally when we do the first scan, we check the evolution. No one does just one scan, one sequence. You just at least need a couple of spin echo. So in my experience, always, unless they are very small, they are always enhancing. I've seen some small lesions in the scalp that are enhancing homogeneously, but just because they are small. But again, if you call this hemangioma, you ask before calling hemangioma, you ask your clinician and they say, it's been born with that, and it's bluish and Valsalva increase. This is your diagnosis. Actually, I have this case from a friend of mine, Lorenzo Pinelli from Brescia, and he's not an head and neck radiologist apart from the petrous bone. And he say, oh, this is an hemangioma or not. It was just above the scalp, but then the description he did was typical of veno-lymphatic malformation worsening over time, venous malformation worsening over time. So I say, call it venous malformation, and this changed a lot the management. So in general, no, do not, if you wait a lot for a large lesion, there is no homogeneous enhancement. But if they are small, yes, this is a possible pitfall. But again, clinical appearance is your friend. I'm glad that there were a lot of attendees here, really glad.
And anyone else? No other questions?
No one asked what we cooked.
Pasta, I told them.
Yeah, pasta, right.
Macaroni, actually. Maybe they didn't understand. We call it macarna.
Macarna.
Macaron.
And we painted as well. Next time I will show you one of your painting. I still have.
Oh, sure. There's one more question, actually. Sure. But that was a good one, actually. My first one, but it was good. How can we differentiate parathyroid cyst and lymph node located in posterior inferior to thyroid lobes?
Yeah, the question is, I don't know, because thyroid they do the body people. So this is the limit. I'm not allowed to. So I'm not sure about this. I don't know if you want to comment, Ali, on that, but I don't. We don't do parathyroid in our hospital.
So they are very rare, honestly. In children, parathyroid cysts and in cystic lymph nodes, they are very rare. But cystic lymph nodes are even rarer. So I don't think it will be possible to differentiate. And it's not an important clinical problem, honestly.
I never came across this differential myself.
Yeah. Most problem it was the same in Turkey, same in Canada. Pediatricians are over worried about the lymph nodes in the neck. and they send children and for the follow-ups, and it's difficult to follow by ultrasound these lymph nodes. And sometimes they ask us to confirm this is not a lymphoma, and it's not possible. So we just describe all the lymph nodes. I just give the largest lymph nodes and tell them that there is no atypical findings. Even there are atypical findings, they can be infectious in children. So that's the main problem, actually.
Yeah, yeah. Okay, Sejal is here.
Okay, if there are no more questions, I think it's 15 minutes. We are over time. So Felice, thank you very much on
Thank you very
behalf
much.
of Turkish Society of Pediatric Radiology. And thank you for everyone joining to the lecture and contributing, asking questions. And I would like to see you in another conference, Felice.
Yeah, sure, possibly live. Thank you very much for the invitation. It was a great pleasure. And have a nice day.
You too. Bye.